important. You will divide your patient into two things. One is ischemic cardiomyopathy and second is DCMP. Remember one thing, if your patient has dilated cavity, dilated LV because of ischemia, you will not label this dilated LV as DCMP, dilated cardiomyopathy, because dilated cardiomyopathy are those patients who are actually non-ischemic cardiomyopathy plus anything which is unknown, which is idiopathic. So more than 20% of the cases in this DCMP are unknown, so you would label them as a idiopathic dilated cardiomyopathy. But if your patient is non-ischemic and your patient has a non-ischemia, like three things, your patient should have three things to label them the ischemic cardiomyopathy. One, infarction, labeled infarction. Number two, hibernating myocardium, like you have labeled them as a hibernating myocardium by doing the non-invasive investigations, okay. And third thing is like severe coronary artery disease. If your patient has 3 vessel disease and your patient has low EF, then you can say that your patient has ischemic cardiomyopathy. But if your patient has dilated LV because of ischemia, because of ischemic disease, because of coronary artery disease, you cannot label them as a dilated cardiomyopathy but ischemic cardiomyopathy. Yes, but if your patient has dilated LV, because in HFrEF you would have a dilated cavity, you would get the dilated cavity in our patients, then you have to divide it into the two, one ischemic and the dilated. So the most common cause of the HFrEF in our patient is ischemic cardiomyopathy. Yes, it is most common is ischemic cardiomyopathy, but few of them are dilated cardiomyopathy, and in dilated cardiomyopathy 20% patients are idiopathic. Now we will discuss that what are other causes, and then one by one we will elaborate them as what you can do for your patients with that dilated cardiomyopathy. Just do remember that those patients who have a dilated cardiomyopathy, if your patient is young in 35 years, if your patient is like female, with the diagnosed dilated cardiomyopathy at the age of 35 years. Now he is presenting to at the age of 55 years with the symptoms of angina and all these things. You have to consider that might your patient would have a ischemic cardiomyopathy or ischemia. So obviously that is the right of your patient to develop the ischemia in the dilated cardiomyopathy. So it is not necessary that in dilated cardiomyopathy your patient cannot come with symptoms of angina or symptoms of coronary artery disease. So you do not have to overlook those patients because of their dilated cardiomyopathy. Your dilated cardiomyopathy patients may develop the symptoms of ischemia, so you have to obviously rule out those symptoms. Now we will discuss about the DCMP. What else in the DCMP we have? Obviously the subclinical viral myocarditis. Subclinical viral myocarditis. The most common cause of the subclinical myocarditis is, you know, that Coxsackie B virus. Coxsackie B virus is the most common virus, most common causative agent to cause the subclinical viral myocarditis in the world, and you have to diagnose it by the PCR, not by the biopsy, simply. And you have to treat it like all other dilated cardiomyopathies if they present to you with a history of subclinical viral myocarditis. Okay. So second we have now the familial cardiomyopathy. You know that most of the time familial heart diseases are nothing but autosomal dominant. Most of the time they are autosomal dominant. Again, this is a familial cardiomyopathy is autosomal dominant, and you in those patients who are young presenting to with the dilated cardiomyopathy with no ischemia, you have to take the history of 3 generations. You have to take the 3-generation history of heart failure or DCMP in these patients, and you have to treat them with the standard therapy of the heart failure but you have to obviously take this history. And in those familial cardiomyopathy, in 40% of the patient you won't get any genome defect. 60% of the patients would be diagnosed, and you will diagnose them with the defected genome, but in 40% patients are idiopathic, or you can say they have the family history of the dilated cardiomyopathy, but you will not get any mutation in their genomes. So what else we have in the dilated cardiomyopathy? Your patient may have present with the history of hypertension or diabetes. So diabetes and hypertension are one of the cause, but they seldom cause as a like hypertension and the diabetes are rarely the cause of cardiomyopathy, because they would not be the lone cause of the cardiomyopathy. They must have something additional to them, like microvascular angina with the diabetes, or hypertension, or persistent chronic hypertension. So might your patient have something else with these things, but these hypertension and diabetes can cause dilated cardiomyopathy. Now the important is the toxins. Toxin, we have obviously the most important, the anti-cancerous drug, the anthracyclines, and the anthracycline doxorubicin is a very notorious drug to cause the dilated cardiomyopathy, and toxin mediated is actually reversible dilated cardiomyopathy. Reversible cardiomyopathy means if you will hold these drugs, then your ejection fraction and the function of heart would get better and would be improved by holding these drugs, or withdrawing, or by the withdrawal of these toxins. So we have anthracyclines here, doxorubicin, epirubicin. Okay, so obviously the doxorubicin is the most cardiotoxic drug, and at the dose of like less than 400, it would not cause, most of the time it would not cause any cardiotoxicity. But at the dose of more than 700, which is a usual dose we usually give in our breast cancer patients and all these patients, so it would 20% of your patient has a 20% chance to develop the cardiotoxicity. So by how you would reduce this toxicity? By giving this doxorubicin in the low infusion form and liposomal infusion. Okay, these two things actually decreases the peak plasma concentration in the blood of these drugs, so they actually prevents the cardiotoxicity in your patients if you have to give the doxorubicin in according to the indication of your patient. Okay, so but keep one thing in your mind, that doxorubicin at any dose, despite of less than 400 dose, they can cause cardiotoxicity, but it has been studied that at more than 700 there are more chances to develop the cardiotoxicity, and less than 400 dose of less than 400, so your patients have less chances of developing the cardiotoxicity with these drugs. So what else you can do for your patients? There is a drugs which is known as dexrazone. Okay, so this is actually the drug you can give your patient with the doxorubicin to decrease the cardiotoxicity. So this is approved for this is approved drug by FDA approved drug to use with the doxorubicin to decreasing its cardiotoxicity. Other drugs such as the trastuzumab and cyclophosphamide are also cardiotoxic drugs, but the most cardiotoxic drug is doxorubicin. And sumitimib drug and the 5-fluorouracil drugs are also cardiotoxic. But the important thing about the 5-fluorouracil is also cause a vasospasm. So if your patient has a history of angina and he or she is taking the 5 5-fluorouracil because of any cancerous disease or for any reason, so you have to rule out the vasospasm in those patients, because might your patient would have a coronary spasm because of 5-fluorouracil. Obviously, now the most important toxin in our developing and especially the developed country is alcohol. We will discuss it later on in detailed form. Right now you just remember that alcohol causes the cardiomyopathy more than 5 drinks per day for more than 3 years. If your patient is taking more than 3 years, then your patient may develop the dilated cardiomyopathy. Okay, but if your patient will withdraw the alcohol, or if you will insist him or her to withdraw the alcohol, then he or she may improve the cardiac function, or he or she may improve their ejection fraction, or their heart failure may improve with the withdrawal of this alcohol. So, but we will discuss about the alcohol cardiomyopathy in a detailed form afterward. Now, the inflammatory cardiomyopathy. Inflammatory cardiomyopathy is another cardiomyopathy because of any inflammation. We will discuss it in chapter of myocarditis in a detailed form, which viruses, which bacteria, and what are the actual causes of all these things. The important thing is the TACI-induced cardiomyopathy. This is again a reversible TACI-induced cardiomyopathy. This is actually the cardiomyopathy caused by the tachycardia. If your patient has persistent rate of more than 100 per minute in any form, like in sinus tach, in AFib, in flutter, if they have a ventricular rate of more than 110 per minute, then your patient may develop tachy-induced cardiomyopathy. Or if your patient has ectopic beats, like PVCs, because of any reason, and how much PVCs? More than 15,000 or 20,000 PVCs in 24 hours, then your patient may develop the tachy-induced cardiomyopathy. But keep remember one thing, that this tachy-induced cardiomyopathy is reversible. If you will treat these causes, if you will decrease the rate, then your cardiomyopathy would get improved and the ejection fraction of your patient would get improved. So it is very important that if your patient has ectopic PVCs, you have to check the source, you have to track them from where they are coming, and if you would ablate the sources, if you ablate the focus, then that ejection fraction of your patient would get improved. And this 110 is the number actually. That's why the upper limit of the rate of the controlling the rate of your patient in the AFib, according to the race 7 trial, it's 110. You have to keep the lenient rate in your patient if your patients are asymptomatic. But if your patients are symptomatic at the 110 in the AFib patient, then you have to keep the rate up to 80 per minute. Okay, we will discuss these things in the atrial fibrillations. Right now, the important thing for us is valvular disorders. All the valvular disorders, as we discussed earlier, because if the valvular disorders, if your heart is unable to push the blood into the system, they would cause the what? Nothing but the dilated cardiomyopathy. That's why your patient, especially the volume overload conditions such as the AR and the MR, they would do what? They cause the dilated cardiomyopathy. They causes the dilatation of the LV. So our valvular diseases also causes what? The dilated cardiomyopathies. Now the important thing we have here is nutritional deficiencies. Nutritional deficiencies. This is actually very important because in underdeveloped countries, the third world countries, have these sort of deficiencies. First of all is thiamine deficiency. Thiamine deficiency is actually, they have a thiamine deficiency as the 2 types, and one is a wet beriberi and dry beriberi. In dry beriberi, your patient would have a glossitis, cardiology, and third thing is hyperkeratosis and peripheral neuropathy. Hyperkeratosis and peripheral neuropathy in dry beriberi. And in wet beriberi, your patient would have nothing but the high cardiac output, peripheral edema. Okay, so in this form your patient would have dilated heart, dilated cardiomyopathy. This nutritional cardiomyopathies are again reversible. If you will treat these nutritional deficiencies, your patient would get improved. The function ejection fraction of your function is actually reversible. You can improve the function of your patient with nutritional deficiencies. So thiamine deficiencies most commonly the thiamine deficiency is most commonly found in which patients? In alcoholics. Our alcoholic patients, most of the time our alcoholic patients have thiamine deficiency because of alcohol and because of obviously decreased protein intake, and get all the energies from the alcohol in the form of carbs. So in alcoholic you would get the thiamine deficiency, and wet beriberi causes this dilated cardiomyopathy. What else deficiencies we have here? What else we have here is like carnitine deficiency and selenium deficiency. Carnitine deficiency and selenium deficiency. So these are the deficiencies actually: thiamine, carnitine and selenium. These are the three nutritional deficiencies which can cause a dilated cardiomyopathy in our patients. So what else we have now? Those drugs which are illicit drug abuse, like cocaine, ice, or methyl methamphetamine, I think it was what was it, the methamphetamines. These are the illicit drug abuse. They also cause what? Dilated cardiomyopathy. So you have to remember, with alcohol you have to remember these two drugs as well, because these drugs are actually very common in the developed countries. Coke use, all these are the very frequently used in the youngsters in the developed countries. So you have to keep remember these drugs as well. Now we will discuss about nothing but the anemia, because it is very important to treat the anemia in your patients. If your patient has defected structural heart disease, if your patient is already have structural heart disease, then less than 9 gram per deciliter hemoglobin can cause what? Heart failure. Can cause heart failure. But if your patient has less than 7 gram per deciliter, then your patient would have heart failure with normal heart. Even normal heart can develop heart failure, the signs of heart failure at the less than 6 gram per deciliter. Then you have to treat this anemia. Then you have to check the anemia. If your patient has iron deficiency anemia for any reason, for blood loss, for any reason, then you have to treat it with iron. You have to treat it with iron. There are actually 2 trials for it, which conclude it that if you will give the patients with the heart failure due to secondary to iron deficiency anemia, then your patient would get them improved earlier, and you will reduce the hospitalization, and your patient symptoms would get better. So these are the 2 trials, FAIR HF trial and CONFIRM HF trial. 2 trials supports the use of iron in heart failure patient with anemia. What? CONFIRM HF and FAIR HF. These were 2 trials confirmed. These were 2 trials which actually support the use of iron in heart failure patient secondary to iron deficiency anemia. Okay, so what else we have? We have like yes, our patient might develop dilated cardiomyopathy because of excess of hemoglobin, such as hemochromatosis. Okay, so we have 2 types of hemochromatosis. One is the primary and second is the secondary. And primary obviously is because of any mutated gene which causes the excess of iron in our body. It is obviously primary hemochromatosis, and secondary because of excessive transfusions in our body, which causes the secondary deposition of the iron hemochromatosis. But the unique thing is that with hemochromatosis, you can develop dilated as well as the restricted form. So in those patients who have hemochromatosis, your patient would have dilated cardiomyopathy, or they may have restrictive cardiomyopathy. So you have to, these are the few actually disorders which can develop both. Now there are so many other cardiomyopathies such as the dystrophies, in which we just have to remember those names: Becker's, Duchenne's, Friedreich's, and second is the Fabry. Okay, we will discuss it later on. These are only I think you just remember these names, okay, or just read their little bit description in your box. So cardiac sarcoidosis and amyloidosis is actually very much important for us. So amyloidosis and sarcoidosis, you know that sarcoidosis is something deposition. It's something deposition of the abnormal. It is sort of the infiltrative disease. So deposition of abnormal proteins in our body, which causes the sarcoidosis. And sarcoidosis causes what? Sarcoidosis is the disease which can present as a patchy involvement. So your patient would have a segmental wall motion abnormalities with reduced ejection fraction. So you have to rule out it with the is this a patient with ischemic cardiomyopathy or non-ischemic cardiomyopathy by doing the coronary angiography in those patients. Okay, so and what else you can do especially to diagnose the patient with the sarcoidosis? This is obviously the cardiac CMR is very important to diagnose the sarcoidosis, because the patchy involvement may mimic as your patient as a cardiac coronary artery disease patient. And second thing, obviously you have to get done the PET scan to check that the sarcoidosis is the older one or the active one. So you do this one. Okay, now amyloidosis does what? Amyloidosis is actually the deposition of, again, amyloidosis. There are the two forms of the amyloidosis. One is again the senile and the wild type, and second is the secondary to deposition of the light chain of the LAMA and the kappa because of any chronic disease. Okay, again this is the deposition of and this is sort of the infiltrative disease, and it can cause but the important thing is that the amyloidosis can cause both dilated and restrictive, like hemochromatosis. So hemochromatosis and amyloidosis can cause both restrictive or dilated cardiomyopathy. The important thing is Chagas here. Chagas is obviously, you know that it is an infection which is commonly occur in the African population, and it is caused by the Trypanosoma cruzi. So it again causes the dilated cardiomyopathy in your patient. But the important thing with this is that these patients would have what? These patients would have conduction defects. These patients would have a conduction defect. Most of the time they patient present with the blocks and dilated cardiomyopathy. Then obviously you have to rule out, if your patient is African having the blocks and dilated cardiomyopathy, then you have to rule out it. Then you have to rule out the Chagas disease. Here we will discuss the few things, and then we will say goodbye. So the important thing which you know, that mixed cardiomyopathy, which are those cardiomyopathies which can present in the mixed form, like dilated and restrictive. So number one is, as we discussed, hemochromatosis. Number two, as we discussed it, amyloidosis. And number three is Fabry disease. And number four is Friedreich ataxia. So these are four cardiomyopathies which can present as a dilated as well as a restrictive form. So these are the common diseases which can present as a dilated and cardiomyopathy form. If your patient has segmental wall motion abnormalities and dilated cardiomyopathy, like segmental wall motion abnormalities plus dilated cardiomyopathy, so you can diagnose it as a coronary artery disease or ischemic cardiomyopathy. But DCMP means you have excluded your patient, that these patients are not ischemic cardiomyopathy. Then what else they can be? So apart from ischemic cardiomyopathy, if your patient has segmental wall motions and dilated LV, then the differential diagnosis would be Chagas and sarcoidosis, because in these both diseases there is a patchy involvement of the LV, and rest of the diseases there are the generalized involvement of the LV. So in that's why in these both diseases you would have the segmental wall motion abnormalities with the dilated LV. So you have to rule out, you have to exclude these patients if your patient is non-ischemic cardiomyopathy and having segmental wall motion abnormalities. If your patient has conduction defects like if your patient has blocks plus dilated cardiomyopathy, then you have what differential diagnosis you have? You have a Chagas, top of the list, Chagas disease, and number 2 is amyloidosis, and number 3 is sarcoidosis, number 4 is Lamin AC mutation. This is sort of dystrophy, muscular dystrophy. So the differential diagnosis, you have a 4 differential diagnoses if your patient has conduction defects like blocks with dilated cardiomyopathy. And what are the reversible cardiomyopathies? As we have discussed here in the detailed form, there are so many things which are dilated cardiomyopathy. We forgot to discuss the peripartum cardiomyopathy. You know that peripartum cardiomyopathy, we will discuss this peripartum cardiomyopathy in the detailed form in a separate chapter. We will just here at the last month of pregnancy up to the 5th month postpartum. So prepartum last month and postpartum 5 months. If your patient would develop any sign of heart failure with reduced ejection fraction and dilated heart, then you would diagnose your patient as a peripartum cardiomyopathy, or you will label them as a peripartum cardiomyopathy if your patient presenting between the last month and the 5th month of the postpartum. So this postpartum is again reversible. So what others we have, what reversible cardiomyopathies we have? Peripartum cardiomyopathy, tachy-induced cardiomyopathy, nutritional deficiency cardiomyopathy, and what else we have? We have like toxin mediated, in which we have anti-cancerous drugs as well as the alcohol and illicit drug use. So these are the reversible cardiomyopathies. Okay, so I think it's enough for today. Now we will discuss inshallah next time we will discuss about the treatment and the management of the heart failure. Then we will discuss it inshallah in a detailed form. So take care, subscribe my channel, press the bell button for the future videos and the future updates. Take care, pray for me. Allah Hafiz.